Well, hello and welcome to Top Med Talk here at Anesthesiology 2025. It's the annual meeting of the American Society of Anesthesiologists. I'm Desiree Chappell, co-editor-in-chief and host today here at Top Med Talk, and I'm joined by my co-host, Dr. Andy Cumpstey. Andy, thanks so much for joining in with me.
Pleasure to be here. Thanks, Desiree.
Yeah. So, Andy, you're a doctor, anesthesiologist from the University of Southampton. Yeah?
I am indeed, middle of the south coast of the United Kingdom, so very, very bottom of the UK, right in the middle.
Oh, there you go. Well, thanks for flying over and helping us out here at Top Med Talk. Andy's been holding down the fort for us here on Top Med Talk the last year, so you've probably heard lots of great sessions and podcasts with him. So thank you so much for doing that, Andy. One of our favorite things to do here at Anesthesiology is to hear from the clinicians who are here, key opinion leaders and researchers doing amazing work in the field of anesthesiology. So our guest today is exactly that. We have Dr. Annery Garcia-Marcinkiewicz. Annery, thank you so much for joining us.
Thank you very much for having me. It's a pleasure.
Please, for our guest, why don't you tell us a little bit more about yourself?
Oh, thank you. Yes, I am an anesthesiologist at the Children's Hospital of Philadelphia.
Or CHOP, as a lot of people refer to that.
I have been there for 10 years, and it has been a lovely experience. We take care of so many patients. We see so many different kinds of airways, and it has just been a fabulous experience to be there and to be part of this incredible team.
That's great. So you mentioned airway. So this is an area of research and of anesthesia that you're particularly interested in.
Yes. I am involved in a lot of difficult airway management from a clinical standpoint and research. It's my area of concentration, and I do all things airway.
All right. Well, many of us listening, I mean, all of us have trained at some point to do anesthesia for the pediatric or neonatal patient, but for some of us, it's been a very long time since we've taken care of pediatric patients. Why don't you tell us a little bit about some of the specific challenges around those PD and neonatal patients that we take care of?
Yeah. Pediatric airway management is really interesting because some of it is getting used to the different anatomical features that a child has compared to an adult. So understanding, anatomic differences, knowing that there's a larger tongue in proportion to the rest of the oral pharynx, a larger occiput, an airway that's more cephalad, right? And patients that you might run out of time, right? Because they consume so much oxygen that is also another challenge that we have when managing those airways, the time pressure component. And sometimes we have the combination of both, an anatomically difficult airway and a physiologically difficult airway.
Yeah, definitely. And whenever we have these patients, one of the things that I think is always a challenge and that I've seen as an evolving challenge is that some of these airways that we're taking care of these really sick kids, does that change things for us?
Absolutely. Yeah. So now we have the challenges that we're starting off with, the anatomical differences, the time pressure, the oxygen consumption. And then on top of that, this child comes in with an illness that is also, posing another physiologic challenge as well. And maybe even creating greater oxygen consumption needs, and now our margin of error is very, very small.
Yeah. So over the years, we know there's been a major evolution in the different ways that we handle airway management for these kiddos. Can you tell us a little bit more about what we're seeing and how things evolve for us?
Well, things have been evolving quite a lot, actually. It's been really wonderful. Years ago, we had just a couple of tools. Yeah. We had a direct laryngoscope, we had a fiber optic scope, and that was basically it. Now things have evolved so nicely that we have companies making products that really are not just smaller miniature versions of the things that we use in adults. They're actually made with the proportions of a child in mind. So it really has given us more flexibility, more optionality, more possibilities for what we can do to rescue these airways. So that's been really nice.
Yeah. I feel like whenever I was training, a long time ago, that it was basically you had to MacGyver everything if you needed something special. Absolutely. I don't know if you get that pop culture reference, but look it up. Well, why don't you tell us a little bit more about the specific research that you're doing there at CHOP?
Yeah. So we have a collaborative, the Pediatric Difficult Intubation Registry. And it's it's a wonderful collaborative started by amazing mentors over 10 years ago. And it has grown. We have 40 centers all over the world. And any time that, we encounter a difficult airway, we then log in, demographic information, case data information, what was done to manage these airways. And then we learn from these experiences to then be able to then, set the next prospective studies and then figure out how to keep kids safe during airway management. So that has been just a fabulous collaborative that has grown over time and has informed even some of the clinical trials that we have done, comparing direct laryngoscopy to video laryngoscopy.
Wow, that is awesome.
And what makes a difficult airway that gets into this database? Is it?
Yeah. So when you have a child that has anatomical differences, so a consideration from by the anesthesiologist who's going to care for them that, hey, this patient would probably not be favorably handled with direct laryngoscopy, or this airway might take many attempts, or just any clinical reason that an anesthesiologist would think that this child might be more challenging.
Always anatomical or anatomical and physiological, as you mentioned before?
For the most part, in the registry, it's been anatomical reasons. Yeah.
Sure. And then what sort of work have you been doing with that data you get in the registry?
One more time?
What sort of work have you been doing once you've got the data in the registry? How have you been looking at it?
Yeah. So after we've been looking at it, then we've been able to inform some prospective studies, and then we've been able to, actually share the knowledge that has been found in those studies. For example, things like we said, some of the devices and techniques that improve your success. Things like anesthetic depth, So when we choose not to provide neuromuscular blockade to a child for some very good reasons, how do we manage anesthetic depth for the entire airway encounter? Understanding that it's not a static process, right? The anesthetic depth that we might need to place an oral airway or a nasopharyngeal airway is different than the anesthetic depth we need to navigate, a scope in the airway or, a device or a blade, right? Which is different than the anesthetic depth that we need to then, get the tube through the vocal cords.
Yeah.
And understanding that might be an incremental, very dynamic thing. So then we've been able to capture that from the registry and then share that knowledge and then actually talk with colleagues from around the world who have said, wow, I've experienced the same thing, and I have had that challenge as well. And then that then guides our teaching. And then from there, we take all that evidence and we partner with colleagues from around the world to then, inform the neonatal airway management guidelines, for example, which really has changed practice.
So I might come back to those guidelines in a second, but you mentioned about devices, and have you been testing different devices and comparing them?
Yes.
So can you give us some examples of what you've looked at?
Yes. So we have compared standard blade VL to direct laryngoscopy. And then we actually did this trial. It was the VISI trial, the video laryngoscopy in small infants trial. And, the idea for that trial came from so many collaborators from the Pediatric Difficult Intubation Registry based on data that we were capturing. And then we said, well, let's go ahead and design this trial to see, once and for all, is standard blade video laryngoscopy more favorable in healthy infants? And then we were able to do that and find that, yes, it does improve first attempt tracheal intubation success by 5% and reduces severe complications, okay? And, you have less need for external laryngeal manipulation and cricoid pressure. And when you have a shared view between the person intubating and the person coaching, there's just better dynamics, better communication.
Yeah. So you mentioned a standard blade video laryngoscopy. Can you break that down? Because in my world and what I use on adults, I kind of get that. But what does that mean for pediatric patients?
Yeah, a standard blade video laryngoscope is the kind of video laryngoscope that if I were to cover the screen, I would be able to perform direct laryngoscopy with. So we're talking about your typical Miller and Mack type blades, okay? And it's interesting because with standard blade video laryngoscopy, you can use it in 3 ways. You can use it as pure video laryngoscopy, you could use it as video-assisted direct laryngoscopy, or you could use it as direct laryngoscopy. So it has that, flexibility and that coaching ability too.
Yeah. So you put the blade in, you take a look, I don't see so much. You look at the screen, and you're like, now you start manipulating, you can find it in first attempts.
Correct.
It's much better.
Or we might have a trainee go ahead, use it, put it in, and then I, as their coach, can say, back up.
Yeah.
Go further, let off, use less pressure, right? And so now I'm able to actually give them information that can be useful just in time.
Yeah. That's
But that adds interesting methodology limitations to the trial, doesn't it? So when you set the trial up, is it protocol as to how to use this device, or is it literally just this device or the other device?
I love that question. That's a very interesting question, and it came up with the design of this trial. And for this particular trial, we used VL as pure VL.
Right.
Okay, we really wanted to test it in the ideal conditions.
Yeah.
Yeah. And another thing on that note, we had most of the patients receive neuromuscular blockade, for example, so that airway reactivity wouldn't be a difference between the two arms of the study.
Yeah.
So just talk us through, so patients are coming through electively anticipated to have an anatomical difficult airway. They're the patients that you're randomizing to either pure VL or standard laryngoscopy?
So actually for the video laryngoscopy in small infants trial, it was on healthy infants.
Fine.
Yeah,
Nice.
for the pediatric difficult intubation registry, those involve difficult airway patients, either known or unanticipated difficult airways.
Got it.
But for this trial in particular, it involved 5 centers. We had 4 centers in the US and 1 in Australia, actually. And then we had healthy infants, 12 months of age or less, who were coming in for general surgery, elective surgery, requiring general anesthesia with tracheal intubation. And so they were pretty healthy, and they were ideal to randomize.
And your primary outcome?
Was first attempt success,
And
tracheal
that
intubation.
improved by 5%, you said?
5%. Okay? Which, when you first hear it, it might not sound like a ton, but a couple of things to keep in mind. First of all, this trial was done in the controlled operating room setting, okay, by people who intubate regularly. So that's one. And then when you look at the data of the trial a little further, and you look at those patients that were less than 6.5 kilos, the smallest, most vulnerable of infants, the magnitude of that success was 12%.
Oh, wow.
Oh,
Yeah.
Great.
So it actually, it improved success amongst all the patients, but particularly in that group.
And
It
was
had the
this
greatest benefit.
in hospitals that this was new equipment, or is there any element of a learning effect or improvement over time with those numbers? Or
Yeah, so there could have possibly been a learning effect as well that we might not have full control over. But interestingly, when we look at the experience with direct laryngoscopy and video laryngoscopy in the trial, it was essentially the same in both arms. It was pretty balanced.
Yeah. All right. So on Top Med Talk, we discuss a lot about research. We talk to researchers and love to go deep in the weeds with that. But then I also like to bring it up to say, okay, this is great. How does this translate into what I do as a clinician whenever I go home?
Mm-hmm. Absolutely. So what this data tells me is that when it comes to pediatric patients, particularly infants, you are better off with video laryngoscopy.
Yeah.
It absolutely improves your first attempt success and it reduces complications. It is the safer, better thing to do for our patients.
Yeah.
Yeah.
so I think that's an important thing. So you mentioned about the complications. What we haven't talked about is, are there any risks to this? But you've sort of answered that. It seems like not. It seems to work.
It
both ways.
really doesn't pose any additional risks over direct laryngoscopy, and in fact, it reduces complications, so it has a greater safety profile. And then, again, particularly in the smaller patients, most vulnerable patients.
Interesting.
So that's another thing that comes up, right? Like, hey, what if, an institution does not have video laryngoscopy?
Yeah.
What do I do, right? So then, based on the data, you want to reserve it for the smallest of your patients, right? So if you have one that you can use all day, save it for that 2-kilo baby.
Yeah.
So, I mean, a lot of my work, as Desiree knows, is in intensive care, and some of my colleagues, we all have that sort of nightmare feeling, which the young child coming in the middle of the night, they'll say, should I be going for video laryngoscope in those patients if I don't use it very often? And your argument is absolutely, by the sound of it.
Absolutely. Start with the best thing first.
Yeah.
Okay, so go right from the get-go, start with video laryngoscopy in that small infant.
Especially when it's standard equipment. I mean, if it's the standard blades
Yes.
that you're used to using, there's no reason that you shouldn't be using.
Correct. And if you really want to perform direct laryngoscopy with it, then you can do that. Just don't look at the screen.
But you have your safety net.
Correct.
right there.
And then the whole room is on the same page as you,
Yeah.
right? So it also improves team dynamics, right? Because everyone can see what you're doing.
Yeah.
And then can give you feedback or know where you're getting stuck to give you help.
Yeah. Well, we keep hearing time and time again that VL is becoming the gold standard for us now, and it really does improve that first attempt of intubation. So I'm glad to hear this. It is. We are seeing the same in our pediatric population, so that's great. So again, as a clinician going back, what is the value statement I think that we can use or tell our hospital administration if we don't have this? A lot of people have it for adults, might not have it for kids. What is the value proposition for them?
I would say it absolutely improves safety. It is better for our patients. It'll help us be more efficient.
Yeah.
And by reducing complications, you're saving on costs.
Yeah.
Many levels of costs, right?
Absolutely.
To the patient, to the family, okay, to the organization.
Yeah, absolutely. And keeping our little kiddos safe, I think, is the very most important thing.
Absolutely.
So, Annery, this has been a fantastic conversation. I could talk to you all day about this. It's really good. I don't think we even scratched the surface, honestly. But thank you for all the work that you're doing in this space and everything that you do at CHOP. I know it's such important work. I always say those that work with infants and children are angels, for sure.
Thank you. It's a great team effort, and I am very proud to be part of that team.
Good. Well, if you ever want to come back and talk to us a little bit more on Top Med Talk, we'd love to have you.
Thank you.
Thank you so much. Thank you so much for listening to Top Med Talk. You know, you can find us at topmedtalk.com. We're on your favorite social platform. We're on YouTube. Wherever you find us, please give us a thumbs up. Give us the star ratings. Give us comments. We love to hear back from all of our listeners. We did want to give a special shout out to our sponsors that make it possible to do Top Med Talk, especially here at the meeting with the American Society of Anesthesiologists. We also wanted to thank Verathon, who has generously supported and sponsored us a couple times now over, and we do appreciate that. Again, to keep Top Med Talk free and open to the entire world so they can hear messages just like Annery's today. So we wanted to thank you so much. Have a great day.